Hello everyone. Today in this video we are going to discuss about transposition of great arteries. So it is one of the most common cause of cyanotic heart disease in children, in which there is a transposition of the great arteries. What do you mean by transposition of great arteries? Before going to that, first we have to know that this type of cyanotic heart disease, congenital cyanotic heart disease, having increased amount of blood flow to the pulmonary artery. So this type of congenital cyanotic heart disease having plethoric lung. So this is one of the main MCQ asked in the all India exam, that name a disease which having name a cyanotic disease, heart disease which having plethoric lung, that is transposition of great arteries. So before going to the discussion details, what do you mean by transposition of great arteries? As we know, the heart having four chamber, and that is the right portion, that is the left portion, and this is the right atrium, right ventricle, left atrium, left ventricle, and the IVC and SBC connect and enter into the right atrium. From here, the blood or deoxygenated blood enter into the right ventricle. From the right ventricle, the pulmonary artery is originated and the blood enter into the lung. And after that, from the lung, it is oxygenated and it enter into the left atrium. And from the left atrium, it enter into the left ventricle. From the left ventricle, it goes to the aorta, and from the aorta to the body. So this is the normal human being. This is the normal phenomenon. That is means right ventricle having connected with pulmonary artery and left ventricle is connected with the aorta. But in transposition of great arteries, that means there is a interchange of these arteries, great arteries. That means the aorta is now originated from the right ventricle and the pulmonary artery is originated from the left ventricle. So what happened by this? So let's discuss the pathophysiology of transposition of great arteries. Before going to that, you have to memorize that if the mother having diabetes, then there may be a chance of transposition of great arteries in the child. So if a mother suffering from diabetes mellitus, then there may be a chance of TGA in children. And you also have to memorize that TGA may be associated with Dye-George syndrome or chromosome 21 deformities. So Dye-George syndrome patient may having chance of having transposition of great arteries. Now going to the pathophysiology, as I said, this is the normal heart, this is the normal heart, this is the TGA heart. Before going to the details of the pathophysiology of TGA, first we have to know the normal heart. As I said, the SBC and the IVC blood enter into the right atrium. From the right atrium, it enter into the right ventricle, and from it is there the pulmonary artery. This is the deoxygenated blood enter into the lung, and in the lung they are oxygenated, and this fresh blood enter into the left atrium, and then from the left ventricle to the aorta, and then to the body. That means there is a complete demarcation of oxygenated blood and deoxygenated blood. But if, and this is the normal phenomenon, and no oxygenation, the oxygenated blood or deoxygenated blood get mixed, so there is no cyanosis in normal human being. But in transposition of great arteries, the pulmonary artery is originated from left ventricle, not from the right ventricle. So as I said, this is the pulmonary artery which is originated from the left ventricle, and the aorta is originated from the right ventricle. So as I said, right ventricle is taking the deoxygenated blood. So deoxygenated blood, that means the unpurified blood enter into the right ventricle from the right atrium, and then enter into the aorta, and from the aorta to the body. That means there is a cycle of deoxygenated blood enter into, goes like this, and there is a parallel cycle is going on the other way, that the oxygenated blood enter into the left atrium due to left ventricle, then enter into the pulmonary artery, and there is oxygenated blood growing parallelly, but there is no connection and there is no mismatch of this blood. So that's why the child will not survive in after birth. Before birth, the child will survive, as because the oxygenation is done by not by the lung, it is oxygenation is done by the placenta. So the placenta oxygenated blood enter into the, from the IVC enter into the heart, and most of the heart oxygenated blood enter into the left atrium via the ASD or PFO in normal before the delivery, that is fetal circulation. But in normal after the delivery, now after the delivery, as the oxygenation is done by the lung, so if the oxygenated blood is not enter into the is not going to the body, and that's why there is a cyanosis since birth. So most of the TGA is divided. So this is the main pathophysiology of TGA. That means the oxygenated blood is going lung and to the heart, and lung and to the heart, and the deoxygenated blood going to from the body to the body and to the heart. So there is a no mismatch. But how there is a cross match of this? If there is a ASD is there, that means atrial septal defect is there, then the blood which is come from the right atrium enter into the left atrium via the ASD or PFO. That means there is a right to left shunt, there is a mixing, and there may be VSD. So from the VSD, the blood which is present in the left ventricle may enter into the aorta or right ventricle. So there may be a right to left to right shunt also. So left to right shunt also. So this is by the, if there is a VSD or ASD or PDA is there, then there may be a mixing of blood. So there, for the survival of the child after birth, there must be either PFO, ASD or VSD or PDA should be there. So it is a duct dependent circulation for the survival of a child. Now, before going to the different types of TGA, we have to know that the TGA is divided into two types, that is DTGA and one is LTGA. D means dextro TGA and L means levo TGA. Dextro means the position of the aorta and the pulmonary artery is divided the TGA into two types, that means DTGA. In DTGA, in normal heart, as we see that the aorta is posteriorly and it is left to the pulmonary artery. So the aorta is posteriorly and left to the pulmonary artery. Right to the pulmonary artery. And in DTGA, the aorta is anteriorly to the pulmonary artery and it is also right to the pulmonary artery. So there is a right to the pulmonary artery that is called dextro TGA. That means the aorta is anteriorly and also the right side from to the pulmonary artery. This is dextro TGA or DTGA. And DTGA is divided into two types according to the VSD. If the VSD is there, or presence of VSD or absence of VSD. So absence of VSD, the child having more cyanosis, and presence of VSD, the child may have cyanosis or may not be having cyanosis. And LTGA, what is LTGA? In LTGA, the aorta is left to the pulmonary artery and there is a corrected TGA. LTGA means, and LTGA, there is a corrected TGA. What do you mean by corrected TGA? This is the corrected TGA or LTGA, in which the right atrium is entered to the left ventricle. So blood from the right atrium entered to the left ventricle. So this is not, this is morphologically, this right ventricle is looked like left ventricle. So it is a morphologically, it is left ventricle. So this is left ventricle. So right atrium enter into the left ventricle, and atrium blood enter from the left ventricle to left atrium to right ventricle. So there is a deoxygenated blood enter from the, and there is also, this is the aorta and this is the pulmonary artery. So this is the pulmonary artery and this is the aorta, and the pulmonary aorta is left to the pulmonary artery. So this is LTGA. This is called LTGA or corrected TGA. Why there is a correction or there is a no cyanosis? Why there is a no cyanosis? Why there is a correction? Because when the deoxygenated blood entered from the body to the right atrium, then deoxygenated blood entered into the left ventricle. From the left ventricle, it entered into the pulmonary artery, and the blood get oxygenated from the lung, and from the lung it oxygenated and the blood enter into the left atrium. From the left atrium to the right ventricle, morphologically it is right ventricle, and from the right ventricle to the aorta, and then enter into the body. So there is a no cyanosis. This is called corrected TGA. So this type of TGA or LTGA, the child does not have any cyanosis. Cyanosis is only happen if there is a VSD is there. So if there is a VSD or if there is a pulmonary stenosis, there may be a chance of cyanosis. So this corrected TGA only having cyanosis if there is a VSD. That means there is a mixing of blood from the right to left shunt, or if there is a pulmonary artery. Otherwise, there is no cyanosis. But in DTGA, there is high chance of cyanosis since birth, and the cyanosis is mainly depend on two things, that is the presence or absence and the size of the VSD. So it is in normal in normal heart, that is left right atrium, right ventricle, pulmonary artery, left atrium, left ventricle, and aorta. So blood, oxygenated blood enter from these like this, enter into the lung, and this is the oxygenated blood, and the oxygenation in the lung, and then oxygenated blood enter the left ventricle, from the left atrium, left ventricle to the aorta. But in TGM, there is a this aorta is there, and there is a pulmonary artery is there, and this is right atrium, right ventricle, left atrium, left ventricle. So deoxygenated blood enter into the this like this, and then enter into the aorta. That means cyanosis just before after birth. So if there is a no VSD, there is a cyanosis since birth. Now, if there is if there is VSD and the VSD size is much less, that means small amount of VSD. That means small VSD. If small VSD is there, the small amount of blood may enter from the left ventricle. That means deoxygenated blood may small amount of oxygenated blood enter into the right ventricle, and so small there is maybe cyanosis. So size, if the VSD size is small, then maybe a chance of cyanosis is much more. If the VSD size is much higher, then there is a complete. If the size is higher, then this huge amount of blood enter into the right ventricle, and there is a complete mixing, and this mixing causing oxygenated and deoxygenated blood, huge amount of mixing causing decreasing the cyanosis, and so less cyanosis is there, and the child may suffering from heart failure. Why heart failure is there? Because the right ventricle cannot cope up with huge amount of blood, and also the pressure of the pressure of the aorta. Left ventricle can cope up with the pressure of the aorta, but the right ventricle cannot cope up with the pressure of the aorta, because the right ventricular morphology and the right ventricular muscle mass is not much higher than the left, just like left ventricle is not much higher. And also the cyanosis depend upon the pulmonary blood flow. If the pulmonary stenosis is there, then that means there is a small amount of blood enter into the lung, and this small amount of blood which enter into the lung getting oxygenated, so decreased amount of oxygenation is there, so chance of cyanosis is there. So this is the main pathology and main clinical features. That means if the VSD is not there, that means complete blockage is there, that is cyanosis since birth. If VSD is there and the size is small, then cyanosis since 2 to 3 hours after birth, and there may be a cyanosis increasing with the age. And if there is a VSD is large VSD or big VSD, then the child is suffering from that is small amount of cyanosis, and the child is suffering from CCF, that means heart failure. Now the diagnosis. When you do the X-ray, chest X-ray shows egg on side appearance. That means this is like this. This is egg on side appearance, and the mediastinum is small. So small mediastinum or hollow mediastinum with egg on side appearance seen in TGA, and 2D echography and color Doppler is the investigation of choice. Now the treatment. As I said, the child if having symptoms, that means cyanosis since birth, and it is a drug dependent, as it is a drug dependent circulation. Why it is a drug dependent circulation? Because as I said, if there is no mixing of the blood is there, then so the body having so oxygenated blood, deoxygenated blood enter from this part. If there is a mixing is not there, then enter into the body, and the oxygenated blood which is come from the lung, it goes to the lung again. So there is a parallel circulation is going on, and child will not survive. So we have to make some connection between these two pathway. So we have to give some make some mixing. So we have to the mixing can be done by the Raskine balloon arterial septostomy. That means we can make the PFO or ASD patent. So there may be mixing on the atrial level, or there may be mixing in the PDA. So prostaglandin infusion. If the child is symptomatic, we have to start with the prostaglandin infusion as early as possible, and we have to do balloon arterial septostomy Raskine operation. So to make the mixing, and after that we have to do the operation as early as possible. Why? Because the right heart cannot cope up with this much of pressure of the aorta, because the aorta having high pressure, and the right ventricle does not have that much of power to cope up with this much of pressure. So that's why the right heart will be getting failure. And if the right heart getting failure, there is a no. If the right heart getting failure, there is a no need of doing this operation, or there is a no health benefit of doing the operation, because if the right heart getting failure, there is a irreversible failure is there. So first, if there is a simple TGA, that means simply there is a TGA without any connection, we start with a costogan infusion and vascular septostomy. After that, we have to do the atrial switch operation, ASO operation. That means atrial switch operation. What is atrial switch operation? As I say, in TGA, there is a pulmonary aorta is originated from right ventricle, and pulmonary artery is originated from the left ventricle. So we have to switch the operation. That means we cut the pulmonary artery and we get attached with it is with the right ventricle, and we cut the aorta from the right ventricle and we attach it with the left ventricle. That is called atrial switch operation. We have to do this operation as early as possible. If the patient having TGA with VSD or PDA or any small amount variable dynamic amount of pulmonary stenosis, then we have to do the atrial switch operation as early as possible and also repair the defect. That means if there is a VSD small or large, or there is there is a PDA is patent, then we have to block the PDA and we do have to do the atrial switch operation as early as possible. If there is a VSD, then we have to put a patch on the VSD. If TGA is present with VSD and pulmonary stenosis, that means VSD and pulmonary stenosis along with the TGA is there. That means it's just like a top phenomenon. So it's just like a top phenomenon. Why? Because the aorta, the VSD is there, and there is a pulmonary stenosis. For the pulmonary stenosis, there is deep cyanosis, and the blood from the left ventricle enter into the aorta because of the pulmonary stenosis. So what happened? So we have to do the BT shunt as early as possible to relieve the to increase the blood flow to the lung. Our main motto is to increase the blood flow to the lung, as there is a pulmonary stenosis is there. So there is a cyanosis. To decrease the cyanosis, we have to increase the blood flow to the lung by the BT shunt. After that, we have to do the Rastelli operation. What is Rastelli operation? The Rastelli operation is just look like this. So this is TGA with VSD and also the pulmonary stenosis. So first, what we have to do? We have to make a tunnel to in the left ventricle. So this is the VSD. So we make a tunnel, and the blood which is come from the left atrium enter from the right ventricle and then into the aorta. So there we have to put a patch and make a tunnel at the VSD level, and we have to cut. We also cut the pulmonary artery from the left ventricle, and we make a conduit. So we put a conduit on there and we connect with the right ventricle. So we make a conduit and we connect with the right ventricle. So blood which is come from the right atrium now enter into the right ventricle, and then from the conduit it enter into the pulmonary artery. So this is it is called Rastelli operation. Now if there is a TGA is present with the VSD and subaortic stenosis, so that means aorta is stenosed, we have to do the BT shunt to increase the blood flow to the pulmonary artery, and also after that we do the Damaski-Stanley operation. What is Damaski-Stanley operation? This is Damaski-Stanley operation. What happened in there is a VSD, so we make a VSD patch, and then we cut the pulmonary artery and main pulmonary artery we have to cut, and left ventricle with there is a left ventricle, the blood enter into the pulmonary artery, we make the cut in the male pulmonary artery and we make a conduit with the aorta. So we connect it with a aorta. So blood from the left ventricle enter into the aorta through the male pulmonary artery, and we attach the right ventricle with the pulmonary artery through a conduit. As there is subaortic stenosis, so we blood small amount of blood enter into the aorta. So that's why we connect the male pulmonary artery with the aorta. So blood can enter from the left ventricle to the main pulmonary artery through the male pulmonary artery to the aorta, and we make a connection between the pulmonary artery with the right ventricle directly with a conduit. So this is called Damaski-Stanley operation. Now if there is a corrected TGA, as I say corrected TGA, there is a no correction, there is a no cyanosis. But if in corrected TGA there is a VSD is always there, and if there is a no tricuspid regurgitation or no right ventricular dysfunction, then we have to do the only the VSD closure. So we have to only do the VSD closure if there is corrected TGA is present with the VSD and no right ventricular dysfunction. But in if corrected TGA having VSD, in corrected TGA VSD is always there. So if VSD is there and along with this there is a right ventricular dysfunction is there, so we have to do the double switch operation. What do you mean by double switch operation? So what happened in corrected TGA? The right atrium, this is left ventricle, and this is left atrium, and this is right ventricle, and the from the left ventricle originated of the pulmonary artery, and the right ventricle originated of the aorta. So what we have to do? We left ventricle, the deoxygenated blood, as I said, enter from the right atrium to left ventricle to pulmonary artery, and this like this. So we have to do what is we have to do double switch. That means left ventricle is connected with a interchangeably shift to right ventricle, and right ventricle shifted to left ventricle, and aorta is attached with the left ventricle, and pulmonary artery is attached with the right ventricle. So blood, so it is called double switch operation. If there is a pulmonary stenosis is there, so then we have to increase the blood connection from the pulmonary artery. So we have to do left ventricle with pulmonary artery connection. And if there is a pulmonary stenosis there along with the RV dysfunction, then we have to do double switch operation. So this is the treatment protocol of TGA. So you have to, who does not remember this type of things, but we have to know the basic pathology. If TGA is simple TGA without any VSD, then we have to do only atrial switch operation. If there is a VSD with PS, then we have to do Rastrelli operation. So this is enough for TG. Thank you.